Good morning. So, welcome to the second session of congenital heart disease. So, this is part 2, right? And in part 1, say in congenital heart disease, right, we divided into two parts, acyanotic and cyanotic. So, in acyanotic, that's what we discussed last time in part 1 when we talked about ASD, atrial septal defect, ventricular septal defect, patent ductus arteriosus, and the coarctation of aorta, right? Coarctation of aorta. Now, these were pretty straightforward, right? Single identity. Cyanotic, you can consider that it is a sort of permutation combination, right? There will be so many permutations and combinations of abnormalities, right? And that's the reason that once you know cyanotic, you'll find that the acyanotic part was pretty easy, right? Reasonably easy. So let's start with the cyanotic part. This is our part 2. Now we have to think from one very special perspective that let's say if there is some problem in left ventricle, right? Always think it like that. So when it comes to heart, how the body was surviving in fetal life, this would be very left ventricle. I'm just giving as an example, but every time whenever today we'll be discussing the abnormalities, right, this thing will come into picture that at times you'll find that in fetal life those abnormalities, they were good, right? How Eisenmenger complex form, okay, we'll take that, right? We'll include that query into our today's discussion. So in fetal circulation, that is, or in the fetal life, those foramen ovale, right? Foramen ovale, then let's say ductus arteriosus, right? All those things, they play important role, but at the same time, they'll be like a survival thing. Now, after birth, the complete hemodynamics will change, right? So that's where we'll see that how these things they can really help. So that's why in today's discussion it would be a sort of combination when we'll be talking about both the things. Here it is cyanotic congenital heart disease, which is like right to left shunt, right to left, right side to left side shunt. Previously it was like left to right shunt, right? In left side there is high pressure, on right side there is low pressure, and because there is, let's say, atrial septal defect, so from high to low, and the blood was flowing. It is when on the right side, when the pressure keeps on rising, right? Because pressure keeps on rising from right side, right atrium, the blood will go to right ventricle. From right ventricle, it will be going into the pulmonary circulation, right? The pulmonary system. Over here, there would be congestion. When there would be congestion, it will lead to back pressure. It will lead to back pressure into right ventricle, right? And then at one point, the pressure on the right side will increase so much so that there would be the reversal of shunt. Now the shunt will be from right to left. This is what is called as the Eisenmenger complex, right? So basically, pathology is left to right shunt, right? ASD, VSD. But what really happens that on right side, as the pressure rises, it rises so much that it overtakes the pressure on the left side, and then the reversal of this shunt, and that is when all those complex things, Eisenmenger complex, it starts occurring. But today we are talking about right to left shunt, and in right to left shunt, as the name suggests, Tetralogy of Fallot, right? Transposition of great vessels, persistent Truncus Arteriosus, Hypoplastic Left Heart Syndrome, Total Anomalous Pulmonary Venous Return, all these things where there will be multiple problems, right? So that's what our focus will be. Another important thing is right to left. That means the carbon dioxide deoxygenated blood would be mixing with the oxygenated blood, right? It will be going from there. And as the oxygen level drops below, oxygen concentration drops below 80%, it leads to all the bluish or the cyanosis, bluish discoloration or the cyanosis. So here our entire idea will be that, sorry. Yeah. So over here there would be abnormal pressure. There would be abnormal pressures. That would be our focus. Second, what we'll watch is that in these cases we'll be requiring surgical correction, right? There would be requirement of surgical correction, and that surgical correction, as and when it will, as per the conditions, we'll see. But this is compulsory to survive. This is compulsory to survive. Then we'll talk about vascular malformation, and we'll look at vascular tumors and the arteriovenous malformation in brief, so that you get the whole idea about what can really go wrong in cases of right to left shunt. So let's start with tetralogy of Fallot. Tetra, right? That means four. That means four. Fallot, that is the name of the physician, right? Who first gave the whole idea. By the way, initially, means this I'm talking about very early, maybe in 16th century, where it was called as the Steno-Fallot. This same thing, it was called as the Steno-Fallot tetralogy, right? Because he was also a physician, this Fallot was also a physician. But later on, this Neil Stenson, his name was Neil Stenson, right? Neil Stenson. His work was not considered that much important, and only this Fallot, that he was given better recognition. So Louis Arthur Fallot, right? He was a physician, and who gets the credit for the complete description and the proper description of tetralogy of Fallot. Now, as such, we'll see that why it really occurs. But it is seen that mother, right, those who are diabetic or those who are alcoholic, right, alcohol consumption, or if her age is more than 40, or during pregnancy, if she has suffered from rubella, so then they are more prone, their kids are more prone to develop this tetralogy of Fallot. Now, the tetralogy of Fallot is four combination. Now, one thing is, straight away we start speaking pulmonary valve stenosis and RVH. We never remember it like that, right? We always forget. So let's go back to our all-time great, our standard figure, right? And we know this thing: right atrium, left ventricle, left ventricle, what goes out. This one would be aorta, this one would be pulmonary trunk. So there would be valve over here, that would be pulmonary valve, this would be aortic valve, this is the mitral one, this is the tricuspid one, and over here this is superior vena cava, this one is inferior vena cava, and the pulmonary veins from both the sides, they will be finally entering into this system, and circulation keeps on going. Now let's change the color and we start drawing over here. Pulmonary valve stenosis. So this is immediately recognized. Okay, yes, that's fine. Pulmonary valve stenosis. So we name it as 1. Done. Right ventricular hypertrophy. This right ventricle is hypertrophied. So let's draw it like this. Right ventricle hypertrophy, right? You remember right ventricular hypertrophy, ventricles hypertrophy, atria, they enlarge, atria are thin walled, right ventricle is thick walled. When right ventricular hypertrophy, we talked about the ECG. Immediately it will be leading to what? Right axis deviation. When we say right axis deviation, so now you know that how we diagnose that thing on ECG, right? We'll talk about it, but because we have already learned, so just sort of quick refresher, which refreshing thing which you'll be doing by yourself, right? We'll talk about it. So right ventricular hypertrophy, so let's name this thing as 2. Third one, ventricular septal defect. Here it is, this is ventricle septum, so this is VSD. right? Ventricular septal defect and overriding of aorta. This is variable, though this is variable, but overriding of aorta. For overriding of aorta, to understand it, draw the aorta like this, like this, like this, and name it like aorta. Overriding. What exactly is overriding? Give me a minute, right? And we'll come to that. So mark it over here. Once you have seen this visually, you'll be able to immediately remember it that yes, this is like pulmonary stenosis, right ventricular hypertrophy, ventricular septal defect, and the overriding of aorta. This is the point which is worth noting. So don't forget this. Now, the way there is tetralogy of Fallot, there can be pentalogy of Fallot. So the fifth condition is also involved, and that fifth condition is nothing but over here when it is combined with atrial septal defect. So if plus atrial septal defect, so then it is called as a pentalogy of Fallot. We need to know this thing in more detail. That's why we'll be diagnosing it. We'll be look at its perspective from ECG, echo, X-ray, CT scan, everything. We'll see so much so that we'll look at even the surgical corrections. Right? Reason? This is most common, most common. 50 to 70% of the congenital heart disease, they are tetralogy of Fallot. So common, right? Now this is extremely common. That's why even at the MBBS level, yes, you should know reasonably well about this tetralogy of Fallot. Another point, 10% of all congenital disease, right? When you consider congenital disease of bones or metabolism, all those conditions you combine together, this one condition is holding 10%. Pretty big, right? Now, this is seen in chromosome 22 deletions. This is very interesting. Chromosome 22 deletions. Now, what exactly is? We know that there are 23 pairs, right? 23. Just wait. Change color. Now it will be fine. 23 pairs of chromosome, right? Out of 23 pairs of chromosome, these chromosomes are nothing but these are like codes in which protein will be synthesized and what it will do. All those codes, they are there. Out of that, out of all of them, this is 22q 11.2, right? Do remember this. This is a sort of address, right? This is a sort of address. So 22, that is easy, right? Chromosome number 22, right? Chromosome number 22. And when we draw chromosome, so this is like there is a long and the short arm, right? This above is the short arm. Short arm is called as the P, and this long arm, it is called as the Q. So yes, we are talking about Q. So 22Q. Then as we go in deep in that, you'll find that the whole arm is divided into regions. So this one is called as the region, right? Then regions are divided into band. So this is band, right? And then bands, they are divided into sub bands. So this is dot 2 is sub band, right? So here we are coming to exact location that yes, we are talking about chromosome 22. We are talking about its long arm, right? In long arm region 1, band 1 and sub band 2. This is the point. This is the point where we are interested in. Now in this much region, which is so specific, still you'll find that there will be about 1.5 to 3 million, right? 3 million base pairs, right? Because in chromosome everything is in the form of base pair, and these base pairs, when they are deleted, that will lead to what's called as the DiGeorge syndrome. DiGeorge syndrome. This is putting a star because these are the questions which are asked, right? So DiGeorge syndrome. Now, any deletion, if it is less than 5 million, right? Any deletion of less than 5 million bases, right? 5 million base. So it is called as the micro deletion. So now we'll correct ourselves and we'll say that when there is micro deletion of 22q11.2, it leads to the George syndrome, which is seen, in which case this tetralogy of Fallot is seen. Because over here, as when we'll be talking about this syndrome separately, we'll see that it affects thymus, it affects, say, parathyroid, right? All those things, they are affected, right? They are affected. And that's how it goes. But these are the important things, right? Chromosome 21 deletions, right? To be precise, 22q 11.2, right? So that's the thing. Now, have a look at this, or have a look at this, right? Look at this only, right? Only this, right? This is boot, right? This is a sort of boot. The similar appearance you will see in case of radiograph of Tetralogy of Fallot. Boot-shaped heart sign. So take it like this one, right? This one, and right. This is what is called as the boot-shaped heart, right? Boot-shaped heart or the clog-shaped heart. Now see, in this case, upper part of the boot, this upper part, upper portion, this is because of pulmonary trunk. The toe of boot, this one, this is due to upward pointing cardiac apex. And this round shape, this whole round shape, this one, right? That shape, that is due to, third point, right ventricular hypertrophy. Concentric means as it grows, right, from all the sides. Now see, when you watch the normal radiogram, normal heart, so that normal heart looks something like this, right? This is the normal heart. Normally it looks like this. So this is where the boot-shaped heart. Achha. Why all these things should really occur, right? To see this thing properly, here it is. We need to understand that what is happening in all those four cases, right? In all those four things. Say pulmonary valve stenosis, well, this is self-explanatory, right? We can understand pulmonary valve is stenosed. Right ventricular hypertrophy, yes, because wherever there is stenosis, so it will lead to back pressure and then right ventricle would be hypertrophied. Barabar, samajh aata hai. Right? Ventricular septal defect, okay, this is also present. So ventricular septal defect, this is also good. What is this overriding of aorta? Now for overriding of aorta, we'll use this space. Let's use this space. And you know this boot proper. Let's use this. Initially, it's like this. This is what is called as the Truncus Arteriosus, right? There is a common trunk. And in that, there is a formation of spiral septum, right? And that spiral septum, that leads to formation of pulmonary trunk and the rest is when the aorta is formed. So they both are separate, right? So here it goes like this, and this aorta, as I changed color, it goes like this. So things are pretty easy, right? Pretty neat. That here it is from right ventricle and from here it is from left ventricle. Though it is left, but because aorta goes on the right side and then it goes posteriorly and all those courses. So far, so good. But what if this septum formation, it is in such a way that situation goes something like this, that as we draw our heart, right, as we draw our heart, what if aorta is coming like this? This is right ventricle, this is left ventricle. Instead of the whole thing which should be coming only from the left ventricle, it is coming like this. So that now this aorta is holding blood from both the ventricles. Let's see this thing into angiography to make it more clear. Here it is. This is angiography. Right, that's angiography. And in angiography, immediately this thing draws our attention that this is right ventricle and this is left ventricle. There is ventricular septal defect. So fine, but look at this. Look at this. That's the aorta, right? That's the aorta. This is aorta, ascending aorta, and O is overriding, right? This is overriding ascending aorta. See, from right ventricle, from left ventricle, right? That's why as it goes up, right, it goes up, right, it is giving all those branches which are used for supplying the various parts of the body. So very clear, right? This is one. Look at this, the second one. This is right ventricle to left ventricle, right? This is the VSD, ventricular septal defect. Over here, that's our CT scan. So on CT scan also, we can very well see that this aorta is overriding. In other words, it is coming out from both right ventricle and left ventricle, both, right? This is the aorta, overrided, correct? So that is the overriding of aorta. You know it very well that there is a ventricular septal defect. Ventricular septal defect, there were three types, right? One was inlet, that is perimembranous. Second was outlet, and the third one was membranous. Membranous was third one was muscular, right? Third one was muscular, and muscular was also called as the trabecular, correct? Trabecular. So these were the three types of VSD, but over here it is the perimembranous VSD what is shown, right? Perimembranous. And then there is overriding of aorta. So these are the two important findings. When it comes to ECG, well, on ECG, any of the tissue, right, if there is any defect, right, this is the ventricle, there is ventricular septal defect, so that means this middle portion is not having that much tissue, but this lack of tissue is so less that it won't be making any significant changes in the ECG. But what we really see is the effect, right? We'll be able to see the effect. So right ventricular hypertrophy, RVH, leads to 1. There would be right axis deviation, right axis deviation. So now we are at a liberty to get two findings. One, right axis deviation. So which leads we'll see lead 1 and lead AVF, right? In lead 1, well, it is down right axis, so it would be minus, this one would be plus. When this is minus, this is plus, this is right is reverse, so we'll watch AVR, and then the lead 2, because in 1 and AVF, so when we draw it like this, right, this is normal, this is the right axis deviation. Over here there are two axes, this one would be 2, this one would be 3, correct? And this is what is coming from opposite side, and this one is nothing but it is AVL, correct? But what we have to figure out is who is 90 degree, right? Who is 90 degree? So 90 degree of AVL, that is this. So that's why we are watching lead number 2, right? So let's write it like this, lead number 2, and our 3 is perpendicular to, over here, right? this one, and this is what? AVR. So that's what we'll see, and you know it very well that when we see that out of these two, who is isoelectric, right? That will give us the degrees. So if AVR is isoelectric, that means this one would be 90 plus 30, so this will be plus 120, and this one would be plus 150, right? So this is just quickly that when we detect RAD, that is right axis deviation. When it comes to right ventricular hypertrophy, this is also very easy. Right ventricular hypertrophy, right ventricle is enlarged. When right ventricle is enlarged, we watch it from the V1 side, so absolutely from the front, and we find that, oh, because right ventricular mass is more, there are more muscles, so that's why the R, right, the rise wave, that would be very tall, right? So it makes sense. So there will be tall R wave, right? So because current will be coming towards, and when we'll see V5 or V6, so over here there we'll see that a large amount of current is going. When it is going, so we'll be having deep S wave, correct? We'll be having deep S wave. R is rising, S is sinking, so it makes things crystal clear. We are talking about QRS complex, right? So these are the findings which you will be watching. And one more finding, right? These are the two things. In case of right atrial enlargement, when we say atrial enlargement, so that means atrial enlargement, P wave is important, right? P wave is formed. Normally, P wave is one. It is because of right and left both combined together. But when one chamber is enlarged, it leads to biphasic P wave, right? So P wave would be like this, right? And this P wave, right, it tells that we are dealing with right atrial enlargement, biphasic P wave. And this is what we'll get in ECG. Regarding the symptoms, all these symptoms, they are purely because of the amount of pulmonary blood flow that will lead to major role in symptoms, right? That will lead to major role. Obviously, it depends upon how much, what is the pulmonary blood flow, right? And that would be leading to right to left shunt, which leads to cyanosis. Now, simply speaking, that's the pulmonary trunk. So over here, because of this stenosis, very less blood will be able to go to the lungs, correct? And because of that VSD, from right ventricle to left ventricle, blood would be pooled. Now this left ventricle is now getting deoxygenated blood. This is the blood which is going into the body. So body is getting a compromised thing. So that's why there would be decreased exercise tolerance. See, remember, this is decreased exercise tolerance, which we saw that thing into Eisenmenger complex, right? Because this blood is going into, that is deoxygenated blood. Blood having CO2 is getting mixed into the O2. So it leads to systemic desaturation. Now tissues will be getting less oxygen, obviously decrease exercise tolerance, and patient with TOF may show the signs of heart failure. Why heart failure? Simply because of fluid overload. The fluid which should have been leaving the heart, right, it is now getting overloaded. So this is right ventricle is enlarged, and then it tries to push that blood into the left ventricle, fluid overload, and the poor feeding, same lack of oxygen, right? So the growth and everything would be badly affected. So poor weight gain, right? Tachypnea, that is the abnormal rapid breathing. You'll find that these things are very similar to Eisenmenger complex, correct? And without cyanosis, that is the initially, that is called as the pink TOF, pink Tetralogy of Fallot. Still, the cyanosis has not yet developed, which develops at a later stage. Now, some children who can walk may show frequent squatting. Now, this is very interesting. Obviously, TOF is such things that life won't be possible if you let it go, right? Life won't be possible. But how the nature works, right? Squatting situation is that this is the baby, right? And baby sits like this, right? Baby sits like this. So legs bent, and then uh, as if it is ducking down. Now, what really happens that in this position, right, it will increase pulmonary blood flow. Why? Because over here, due to this posture, femoral artery, right, that would be kinked. That would be kinked. So this will be squeezing venous blood into the systemic circulation, right? So this is how there would be increased blood flow, right, by squeezing systemic venous blood and increasing systemic resistance. So what would happen in this case? Very easy to understand. Again, let's draw our heart, right? The standard heart. From here there is aorta. From here there is aorta. There is, remember, there is ventricular septal defect, right? There is ventricular septal defect. So, and this one is right ventricle, this one is left ventricle. Now, our blood is coming over here, right to left. But now this aorta, you know that all the way aorta, it goes down, right, in the form of descending aorta. Then descending aorta divides into common iliac into external iliac, internal iliac. External iliac is something what is called as the femoral, right? When you are compressing them, so it is like generating a back pressure. So thus the pressure into the left ventricle rises. When it rises, so relatively it will give resistance against the right ventricle, right? Right ventricle is trying to, here also pressure is high, but right ventricle is trying to send blood, but again because of resistance into the left ventricle, this flow decreases and patient becomes comfortable, right? So this is like nature, right? In that position, who has taught that kid to sit in that position? But no, you'll find, you'll actually see that they will be sitting with their legs bent and ducking down. This is what is called as the frequent squatting position, right? So this is one. Idea is increase the pressure in the left ventricle so that from right ventricle blood is restricted, right, which is passing via ventricular septal defect. Next is hypoxic spell, right? Hypoxic spell. Two things. Two things we understand. This is hypoxia, and then there is another similar word. One is hypoxia, and second is hypoxemia. Hypoxia and hypoxemia. When it is hypoxemia, so there is decrease in the oxygenated blood, right? Decrease. So in this case, obviously, the most important is heart and brain. They are affected. These are the tissues once dead, gone forever, right? In case if there is any lack of oxygen to liver, spleen, lungs, so even if partial organ is dead, doesn't matter, rest of the organ takes over. This thing never occurs in heart and brain, right? So it's so important. Acha. So hypoxic spells sudden occurrence of severe cyanosis, deep and rapid respiration, irritability, and then the lethargy. Person is tired. Lethargy means the person feels tired, right? This is due to lack of oxygen to tissues, right? Lack of oxygen to tissues. And this typically occurs around 2 to 4 months of age. So in very young age, this starts. Now, see, hypoxia spell lasts for long duration, right? And without treatment, it can lead to seizures, convulsions, hypoxic brain damage, and finally even death, right? So that's the thing. It is so much dangerous. How will it really look like? Say this is our normal finger, and then that's the normal nail, right? So this is how it will look like. That's the normal nail, right, which will be looking like this. In case of clubbing, this is what is called as the clubbing. In clubbing, this nail bed it goes like this. This is clubbing. So see, over here, over here, over here, right? That's clubbing. Clubbing in lips, clubbing in those fingers and toes, and you'll find cyanosis in lips and fingers. So why this clubbing should occur? Again, this is because of the peripheral resistance, right? So this is a very typical appearance, right? There are so many other reasons of clubbing also, but that's how in young patient, when you look at it, so think of this tetralogy of Fallot. So these are cyanosis, bluish, and the clubbing in fingers and toes. For diagnosis, nothing like echo, right? Nothing like echo. And see, left ventricle, right ventricle, and instantly it is seen that here is the aorta and here it is, right, which is left ventricle. There is ventricular septal defect. This is right ventricle, and this is right ventricle, right? Here it is, right? This is right ventricle, and classical situation. Ventricular septal defect is shown, aorta overrided, it is shown, right? And this one would be the atrial septal defect, which is fine. Over here, look at the size of left ventricle against right ventricle. Looks wise only, you immediately come to know that right ventricle is enlarged, right? So that is also quite seen effectively. Treatment, nothing. Nothing can be done except the surgery. One has to correct it, right? So these patients, if surgery is not done, hardly they reach to adulthood. And in one of the recent surveys, it was quite interesting that survival rate of patient reaching to 36 years, right? If the surgery is done in young age, right? Almost 86% of the patients, they see their 36th birthday, right? Now this is important because such patient, even if they are surgically corrected, still life is not very long, right? So that's why from the insurance perspective, many times you will find that such patients, they go for insurance because they know that they are like living time bomb, right? So obviously in surgery, this is open heart surgery, and in this you have to create the shunts, or you have to really create what is incorrect. So one, which was pulmonary stenosis, correct? First one was pulmonary stenosis. So in pulmonary stenosis, that is what we have to correct. So pulmonary constriction is to be relaxed. So this pressure is released. It goes further. Second, very important would be the VSD, ventricular septal defect, so that blood is not shunted. So VSD is corrected. Makes sense, right? When these two things are done, our third finding, right ventricular hypertrophy, nothing much can be done, but when these two things are resolved, right ventricular hypertrophy, it resolves by itself. It takes time, but it is done. The fourth thing, the overriding of aorta. Well, this is the most complex thing, but it is variable, right? This finding is variable. But if it is present, so it definitely requires attention, and we have to correct it. It has to be corrected, this overriding of aorta. Plus, if it has got, it is pathology, if it has got ASD, so then you have to take care of the ASD also. You have to correct, or right, or the repair ASD. So just by the looks itself, it seems that yes, things are pretty complex, right? So that's why post-surgical complications, there can be so many complications, but the commonest complication, if it is asked, never forget, it is ventricular arrhythmia, right? It is ventricular arrhythmia. This is one of the major post-op killer, right? This is the major post-op killer. Major. So when the death occurs, most probably it is because of the ventricular arrhythmia. No doubt there are some other complications, but this is the vital. Moving on to the next one, this is transposition of great arteries. Transposition of great arteries. So great arteries, we are dealing with what? Only two arteries are great, right? One is aorta and second is pulmonary trunk, right? Pulmonary trunk. So what is transposition? Transposition is when they switch. When they switch, that means from right ventricle, the pulmonary trunk should come out, correct? And from left ventricle, aorta should come out, ठीक है? But they switch their position. Switching is that now it's not like this. It is like from right ventricle, aorta is coming out, and from left ventricle, pulmonary trunk is coming out. It means that whatever the blood which is in left ventricle, now it is going into pulmonary trunk. To understand this, that how dangerous, how serious this thing, right? Forget about this and let's draw our all time, right? Our standard heart, right? Not this, right? Not this, don't draw this, but this. And let's draw it like this. So standard right atrium, and this is left atrium. Right ventricle, left ventricle. So far so good. ठीक? And we said that aorta will come out from the right ventricle. Okay, aorta is coming out from right ventricle. From right ventricle, where it will go? Well, it will go into the body, right? It will go into the body. That is the normal anatomy of the aorta. From body, it will circulate, and then veins would form, and finally superior vena cava, inferior vena cava, and the blood will go back into the right atrium. Fine. Okay. Here is it. From left into the left atrium, who will be giving the blood? Those pulmonary veins from the lungs, good, fresh, nice blood, right? From left ventricle. From left ventricle, it is going where? It is going into, because they switch positions, so it will go out into the form of pulmonary trunk. Pulmonary trunk divides into right and left pulmonary artery, and they land into the lungs. Lungs, right? And then from lungs again the circulation. Now see what has happened. We have got two circulations. We have got two circulation, and this is what is called as the parallel circulation. Parallel circulation. This condition is such that it is impossible to survive, because body won't be getting any oxygen, and so one group of blood is circulating into the aortic, that is the systemic circulation, and second one into the pulmonary circulation. They both will be completely separate, and this is what really happens. The atrioventricular concordance, right? Remember these words. This is atrioventricular, right? Atrioventricular concordance. Concordance means, they die. They usually, yes, they die at birth. But then there is something by which they survive. They don't die at birth, right? So if so, we are coming to that, right? Very interesting thing. There is atrioventricular concordance. Concordance means they work together happily, right? So this concordance is a happy thing, right? Happy thing. So concordance is happy. It means that they are working together nicely. All well. Discordance means no, they are massively incorrect. So over here, this makes sense. There is ventriculo arterial discordance. There is a problem between ventricles and the arteries. Yes, that's the problem, right? That's the problem. This is the problem area. This is the problem area, right? So there is atrioventricular concordance. Things are good, right? But there is ventriculo-arterial discordance. So how come? This is right atrium to right ventricle to aorta. Correct? 1. Aorta will have deoxygenated blood. Sure, Absolutely, because there is no one. Whatever the blood which was there, used up by the body, and then same blood, right? It is going round and round. No support from lungs. That's why survival would be difficult, right? And left atrium to left ventricle to pulmonary artery, right? And it goes on and on. So this is like pulmonary circulation, and this one is our systemic circulation situation. Extremely bad, extremely bad, right? Not at all good. Now see, in this case there are two types. This is transposition of great arteries. So from this point onwards, now we'll start writing it as TGA. Okay? From this point onwards, we'll write it as TGA. Now, transposition of great arteries, this is like there is a combination of things, right? So many things are happening. But there are two types. One type in which there is, when we say that there is atrioventricular concordance, right? We talked about it, atrioventricular concordance. And but there is ventriculo-arterial discordance. Two types, one which is dextro-TGA and second is levo-TGA. So first let's talk about DTGA or the dextro-TGA, right? Dextro-TGA. Here it is, right? So this is about dextro-TGA. Three things can occur. Three things. Complete TGA with intact ventricular septum. See how the nature is trying to protect the things, right? So over here, if there is complete TGA, right, completely opposite, right, which is 50% with intact ventricular septum, okay? So this is one. Now if there is intact ventricular septum, this is like both are completely separate, right? There is no mixing of blood. ठीक. But with VSD, so now things will be like this. Say that's the ventricle, and over here we have got ventricular septal defect, right? So though this is going towards what? This is right ventricle, this is left ventricle, this is aorta, this is pulmonary trunk, right? But this, due to VST, some oxygen is available, correct? Some oxygen is available. This is that situation. Complete TGA with VST, right? Complete TGA with VST. And the third one is complete TGA, right? Complete TGA with VST, ventricular septal defect and pulmonary stenosis, right? This is pulmonary stenosis. See, in the beginning I told you that in case of, say, these cyanotic systems, that would be all combinations, all possible combinations, right? So complete TGA with intact ventricular septum. So that from this point onwards, we'll be telling IVS, intact ventricular septum, right? 50% of the cases. VSD 30%, and VSD and pulmonary stenosis both, that is 20%. It changes everything, right? It changes everything. The complete hemodynamics change, right? So if the question comes that if such type of things are going on, so how baby is going to survive? How baby would survive? In case if there is complete TGA with intact ventricular septum, so then there is no possibility, na, right? Correct? There is no possibility, right? From here it is going to this aorta, from aorta it is going to body, and then body to vena cava, and this is the right atrium, this is right ventricle, tuck 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 tuck, it keeps on going, right? Over here there is like left atrium to left ventricle to this is pulmonary trunk, and then it is going to lungs and then going back. Both are parallel circulation. But here it is. Two things which will make them survive. One is that apna foramen ovale, right? So blood starts getting mixed. The moment it mixes, yes, oxygen has started coming. And the second is what? Ductus arteriosus. है ना? Ductus arteriosus. See, you remember ductus arteriosus, because initially so it was like even that thoda hua bacha kucha blood bhi, whosoever is passing through, whosoever has escaped that foramen ovale, it went into right ventricle. From right ventricle it went into the pulmonary trunk, and from pulmonary trunk, why should it really go to lungs? So by that channel, this ductus arteriosus is once again it goes back into aorta and it's saved, right? But now this ductus arteriosus, it becomes the lifesaver. Ductus arteriosus, now it is connecting aorta and pulmonary trunk. So at these 2 points, things will be exchanged, right? Oxygen, carbon dioxide, they will be exchanged, right? The blood will be mixed. As such, baby is never getting pure blood, correct? As such, baby never gets pure blood. It is always the mixed blood, right? Even in fetal circulation, you remember, that is at foramen ovale, right? What is happening? The blood is getting mixed, you know? In normal fetal circulation. Ductus arteriosus, what is happening, right? It is getting a mixed blood. Even right from the beginning, right? It is the mixed blood which is getting circulated, and the tissues, they extract whatever the oxygen which is available. So now you have to think from one very, very interesting perspective. Ductus arteriosus, right? Why it remains open? It remains open because of the placenta. Placenta releases what? Placenta releases prostaglandins. Prostaglandins. And in presence of prostaglandins, right, this ductus arteriosus remains open. The moment baby takes birth, baby cries, right? Baby cries, foramen ovale shut, right? Foramen ovale shut because the resistance is decreased, right? So now left atrial, left-sided pressure rises and it shuts down the flap, right? That septum primum, septum secundum, they both join, and then there is that fossa ovalis which is formed later on, but it is joined. Ductus arteriosus, it closes because placenta has been taken away. That's when now no prostaglandin, lack of prostaglandin, ductus arteriosus closes. In such cases, what if you give externally prostaglandin? So now ductus arteriosus will remain open and you have got the chance to survive this baby, right? Because ductus arteriosus, if it closes, so bas khatam. Now then nothing. Then immediately they both will be like parallel circulation, right? Let's see some angiographies, right? See such classical angiographies, right? Very rarely some things are seen, but this is very classical. Why? Because this is complete TGA, complete transposition of great arteries. How come? We have injected dye into the right ventricle, right? This is the catheter, right? We have injected the dye into the right ventricle or the contrast media. This contrast media is going into aorta, right? See, and it is this is the arch of aorta and it is going down. So yes, this is one part, right? What you now do is, and yes, can you really see over here? Over here, there is left ventricle. Left ventricle is not filling up, right? So you can say that which type of it is? This is type 1, right? See, type 1, complete TGA with intact ventricular septum, right? So over here, because we don't see our contrast media, so we can say that there is intact ventricular septum. So we are dealing with type 1 of TGA. Okay? To confirm this thing, so it is like a temporary measure till surgery. Very right, very right. You see, it is absolutely temporary. Very right. But say when you diagnose, so you need some time, right? You need some time. Otherwise, so say this parallel circulation goes, so within minutes the game is over. The moment that ductus arteriosus closes, finished. है ना? अच्छा. To confirm this thing that it is type 1, we do one more thing. We inject the dye. We take the catheter. Now we are putting it into left ventricle, and from left ventricle we inject the dye, and woo, it is going into the pulmonary artery, right? Pulmonary trunk and pulmonary arteries. And over here, the right ventricle is there. Right ventricle is completely empty, right? So this indicates definitely that there is intact ventricular septum. So we are talking about type 1, that is confirmatory. This will help. This will help in what type of surgery you have to do, right? So this is why this is complete TGA with intact ventricular septum. That means no VST, right? The type 1. Now you can understand that if you get some leakage into the left ventricle, that means 100%. This is with VST, right? This is with VST, ventricular septal defect. So it becomes type 2. And then in this, if you find a stenosis, sorry, let me change the color. If you find that the shape is like this, right? Because now you'll be watching very specifically, let's remove this. Just looks by it, it tells ki yes, that pulmonary artery is bindas, right? It is good, right? Fine. The flow is going fine. If the flow is going like this, right? If it is like this, so then you know that dye is going on to this side also. So this means we are dealing with type 3. That is there is ventricular septal defect, there is pulmonary stenosis, so it becomes type 3, right? So that's how things go. So this is typical type 1. Now, watch this. This is one of the finest X-ray. So many things you will watch in this, so many things, right? First thing first, what we have done is, sorry, what we have done is, right ventricle, the dye is getting injected, right? So this is the beginning. Or this color is seen? No. Let's take white. We are injecting the dye, right? Contrast medium is going. As it goes, see, it is spilling into this side, right? It is spilling over here. This means this star, right? This star, where the star is, this is a small ventricular septal defect. This is VST, right? It is going, see, it is spilling into this. This is the right ventricle, left ventricle, right? So from right ventricle to left ventricle it is going. So this is the VST. Then that's the right ventricle, and from right ventricle, see the aorta, right? You can immediately see that this one is brachiocephalic trunk, this is left common carotid artery, and then the subclavian artery, right? Over here, subclavian artery, right? And this is the arch of aorta. This is arch of aorta. I'll remove these lines because we need to see some more things, but this is for understanding. So this means third point, which is crystal clear, it is that we are dealing with complete transposition of great arteries, complete TGA, right? Because of this aorta. Now I'm removing these lines because we have to watch certain more things over there. So this is third. Fourth thing, which is very classical. Can you see the bore or the caliber of this aorta? Now see, when we draw the aorta, you have seen even the aorta into its normal anatomy, right? It is a thick tube, very parallel, thick tube. And then those brachiocephalic and then left common carotid and subclavian, they go, right? This is the arch, and from arch there goes the descending aorta, and so the thick tube straight away goes down. See, it happens like it goes over here, and then there is see, its bore decreases, and then once again it increases, right? So there is a structure. I'll remove this and you will notice it. See, there is a narrowing. watch for this area. There is a narrowing. So this is coarctation of aorta. That's our fourth point, right? It is coarctation. And when we say coarctation, from the last time you remember it, right? When arctation of aorta. So as it continues, you'll be able to see the inferior rib notching, but that is at a later stage, right? It won't develop immediately because those pulsatile intercostal arteries, they should really put a notch on the inferior surface of the ribs. Then and then they'll see. In the initial stage, we won't be able to see because it takes some time to develop, right? So this is the fourth point. So 1, 2, 3, 4, and one more thing. So many complications in one. That's why, see, we deliberately took the acyanotic first because in cyanotic heart disease, multiple things occur together because it is a complete, the developmental, the embryology goes completely haywire, right? That's the reason that this pediatric surgeon, this is like a super specialty because you have to correct so many things. One more thing, as we said, coarctation of aorta, but can you really see that? See, if this is the arch of aorta, this arch of aorta is becoming smaller, right? It is becoming smaller. So this arrow is indicative of the fifth complication, and that is hypoplastic. Hypoplastic. It has become smaller. Hypoplasia or the hypoplasia, right? Hypoplasia of aortic arch. Aortic arch. So that aortic arch is becoming small. And the best, which is so prominent, and this is what we are watching. See this? Changing the color, changing the color. Yeah, this you can see over here. And this one, right? This is what? This is PDA, patent ductus arteriosus. As from the left ventricle, the trunk which is going out, right? The pulmonary trunk, when it is going out, it is leading to the combination of, see, I'm this, right? This is a thick, such thick ductus arteriosus, and this is patent, right? See, this is patent ductus arteriosus. So this one is the sixth one, that is the patent ductus arteriosus. So there are 5 complications. I wrote one because this is just to indicate that from here we start, right? So it was for understanding. So basically 5 complications. All these 5 complications, one, right? Complete TGA. Second, we saw that ventricle blood was going into the left ventricle, so that is ventricular septal defect. There is severe coarctation of aorta. Yes, we saw that. Hypoplasia of aortic arch. Yes, we saw that. And there is patent ductus arteriosus. These are the things which we are watching, right? And in that, our one was like injection of contrast media, right? That was just for understanding contrast media. Right. So basically we have got 5 complications, right? So these are the complications. So starting with, it was the ventricular septal defect, complete TGA, then we have got severe coarctation of aorta, narrowed hypoplasia of aortic arch, and the patent ductus arteriosus. In fact, patent ductus arteriosus is a lifesaver, right? Otherwise this patient won't survive even for this angiography. Right? You got it? Achha. See, this is when the 2D echo is done, right? 2D echo. In 2D echo, nothing. Left ventricle is what? PT, pulmonary trunk, right? Right ventricle, right, leading to what? Aorta. So complete TGA, right? So that's what we see. Now in this case, right, here it is mentioned. So hemodynamics is, this is interesting, right? Though we have talked about it, but still we sort of revision. unoxygenated blood, right? This is like CO2 from superior vena cava, inferior vena cava, because body has used that oxygen. It goes into right atrium, to right ventricle, to aorta, and that once again into systemic circulation, right? It is moving on and on. So this is like complete CO2 rotating, right? Second, oxygenated blood, because lungs have come into picture, from pulmonary veins to left atrium to left ventricle to pulmonary arteries to pulmonary circulation. It goes on and on and on, right? And this is oxygenated blood, and this is what is called as we have talked about it, parallel circulation instead of normal circulation, which is in series. In series means blood, deoxygenated blood, it goes to lungs, gets oxygenated, goes into the body, circulates, right? And that's how it goes. They both are in tandem with each other. These are parallel circulation. So therefore, without mixing of unoxygenated and oxygenated blood, patient is bound to develop severe cyanosis, right? No doubt about it. Hypoxemia, right? Metabolic acidosis. Metabolic acidosis is when there is severe electrolyte imbalance, right? This is a huge topic, severe electrolyte imbalance, right? In physiology, yes, this would be like a beautiful topic. And there are so many chemistry that it will be coming into picture, but it is because of that acid base imbalance in our body, right? So there can be increase in the acid or decrease in the bicarbs, right? Decrease in the bicarbonates, or when the kidneys, they are not functioning properly, so kidney problems. So all those things, they can lead to, say, metabolic acidosis, and will die soon after birth, right? Mostly within a week, not even a week, even before that. Right ventricular hypertrophy and left ventricular atrophy, right? Because there is no pressure, so left ventricle will become smaller and there would be atrophy. There won't be much of the problem, right, in fetal life. Now this is what is painful. What happens is that you if you don't anticipate, right? So when the mother is pregnant, to you, when you do ultrasound, right, when you do, say, ultrasound, because you won't be able to do CT scan, right? CT scan cannot be done in case of pregnant female because of radiation. So you have to rely on ultrasound. Ultrasound is safe, it can be done as many times as you like. If you don't anticipate, after birth, right, immediately cyanosis will start developing, and there is no way. So such patient, they require ventilator support, immediate surgery, which is like a switch operation. So you have to really switch it. And this is the point where prostaglandins will be playing a major role. Prostaglandins are to be started instantly, so that you want that ductus arteriosus remains open. So if this is not anticipated, think from the perspective of a non-medico. They will say that all the way from first to 9 months, everything was fine and doctor was not understanding, and the patient died immediately after birth, right? This is like a mental trauma. Plus, this is such a situation which requires the pre-preparation. That is, when the baby, the moment it say delivered, you need to start this thing, right? So that's why it requires proper preparation right from the beginning. Prostaglandins given so that ductus arteriosus remains open, right? Remains open. Very simple thing, right? Very basic principle, but so important. So that's the reason that when I say that it is fine that one can learn these things into when you'll be coming into final year. But till that point, that if a question is asked that ductus arteriosus remains opens because of, many times we tend to forget, right? Prostaglandin, and even we feel that theek hai, what's the importance? But now you will never ever forget the importance of prostaglandins, because it is so important in such cases, right? Acha. How the patient would, when you take the X-ray chest. So this is like, think it like this. This is like egg, right? It is called an egg on a string, as if the egg is hanging on a string. This is the type of X-ray chest, X representation. right? No doubt, this is for the radiology, right? No one would ask you this thing, but good to know, right? Egg on a string appearance. Okay. So this we talked about dextro TGA. Now we talk about the levo TGA, right? Levo TGA. Now this is still amazing. No doubt this is, I should not use the word amazing because this is dangerous. But this is very rare. This time, ventricle switch position, right? Ventricle switch position. So it happens like this, right? Let's draw the heart. Let's draw the heart, right? Our standard way. So right atrium, left atrium, so far okay. But now the right atrium opens into left ventricle and left atrium opens into right ventricle, right? Now right ventricle or left ventricle, we might say that, acha, ye to we are giving the name, right? Who is on the right side, who is on the left side. No, 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 no. Remember, right ventricle, because they have switched position, it is along with the valve, right? With valves, right? So you can say this is congenitally corrected TGA. God has corrected it, right? But there are complications. What? The valves have also switched off, right? Valves have also switched. So right ventricle is associated with which valve? Tricuspid valve, right? Am I right? Right atrium to right ventricle normally. So there is a tricuspid valve. Right ventricle has moved along with the tricuspid. So this one is the tricuspid valve, right? And the mitral valve is now on this side. This is the mitral valve. Rest, all good. So left atrium is getting the blood from lungs, right? It goes via tricuspid and it goes into the right ventricle. From right ventricle, only the ventricles have switched. Rest of the aorta and I have not switched. So here it will come out from the aorta. From aorta, blood will go into the body. From body, right, it will use, and then all the way it will be going into the form of those vena cava. From here it will come into left ventricle, right? And from left ventricle it will go into the pulmonary trunk, and from pulmonary trunk it will go into the lungs, right? It will go into the lungs and circulation goes on. As such, if you see, this is the reason which is why it is called as the God has corrected, congenitally corrected TGA. God has corrected it, right? So basically, as such, if you see, this is like a normal heart. There won't be any cyanosis. This is acyanotic, right? But something happens in this case. This tricuspid valve was never made for power. It is the mitral valve which is so powerful. Tricuspid valve is not that powerful, right? Because in whole life it has to undergo so much of pressure. Now this is, as this patient grows in adult, it leads to valve failure. Because tricuspid handling high pressure, so it leads to valve failure. And if the risk factors, why it can really occur. If pregnant mother is having PEM, protein, energy, malnutrition. See how important the protein is, right? Protein, energy, malnutrition. Diabetic, alcoholic, 40 plus, rubella. Aren't they same which was leading to Tetralogy of Fallot, right? So that's why these are very vital factors. That's the reason, say, I'm not telling anyone at a personal level, right? But what I'm telling is that I have seen many of the females, right? They say, okay, so what? Even if they are pregnant, right? They are going to parties, they do consume alcohol, right? Say when we understand this thing, how dangerous can it be, right? And with due respect to everyone, but any baby born with congenital problems, it is like a liability, na? Liability. It is not an asset to the society, right? One cannot throw away that baby. So this is like a liability, and that liability is for whole life. So that's why some things which can be avoided, right? Protein, energy, malnutrition, protein, diabetes, right? With proper exercise and proper lifestyle. Why to let the diabetes develop? Then alcohol, which can always be avoided. There is no advantage of alcohol, right? It is the addiction thing. 40 plus rubella. These are the things which can be treated. Okay, moving on to the third part, the truncus arteriosus. Now, not to be confused with ductus arteriosus, right? So, crystal clear, right? Ductus arteriosus was what? Ductus arteriosus was the combination, right? Was a tract, was a duct between aorta and pulmonary trunk. For that, every time I say that bacha kucha blood whatsoever, it should not be wasted. The blood which has escaped through foramen ovale, it went into right ventricle. From right ventricle, it goes into the pulmonary trunk, and aorta tells ke lao, give this blood also to me. And that's where the ductus arteriosus comes into picture, and the aorta takes the whole blood. Nothing is going to the lungs. This is in fetal circulation, right? Truncus arteriosus is completely different. Truncus arteriosus is that trunk, right, in which there is a formation of that spiral segment, right, spiral septum, and it leads to formation of the large arteries. So initially, I would really draw it like this. So let's draw our heart like this, right? Very simple. So right atrium, right ventricle, left ventricle. Say this is it divides it into, as we said, pulmonary artery, that is pulmonary trunk and aorta. But if this truncus arteriosus is not getting divided, situation will be like this. This is what really happens. This is the easiest explanation. Otherwise, they divide. So this right ventricle, it goes into the pulmonary part. Left ventricle, it goes into the aortic part. So far good. But this is normal. It's not happening like this. Now, because this truncus arteriosus, that septum, spiral septum should develop and it should divide it into two parts. It's not happening. So there is like a common chamber. This becomes a common chamber, right? Both the blood, they are coming up. This is the mixed blood which is coming. Okay? So how will it look like? Say in the case of heart, right? In the case of heart, right? From the right ventricle and the left ventricle, there would be a common trunk which will be going, right? So this would be like a common chamber, right? Mixed blood. So what complications? It's similar to overriding aorta. That's right. But in overriding of aorta, what was happening? The aorta, right? The aorta was emerging from this. Here, there is nothing like pulmonary trunk. Both pulmonary trunk and aorta, they both are same, right? So cardiomegaly, right? There is pulmonary hypertension because the blood which is from left ventricle is also getting pushed into the pulmonary circulation. So that can lead to permanent lung damage because this is hypertension. As such, pulmonary hypertension is dangerous, right? Because lungs are very delicate. Now, immediately after this, we'll be starting with lungs. So at that point, once again, we'll come back to these things, that how the lung tissue, they can damage. Remember, lung tissues, they are extremely delicate. very delicate. And we'll be looking at its surfactant, we'll be looking at emphysema, we'll be looking at what happens in various type of pneumothorax, right? But the point is, it is delicate, and lungs are super lazy. They are always tendency to collapse, right? It is because of that chest, because of that negative pressure, because of that pleura, right? They are keeping it distended, right? That's the reason when we inhale, right, it requires energy. Exhale, nothing is needed. It's a passive process, right? No energy is utilized for exhalation, for expiration. So this is the thing. Pulmonary hypertension, as the tension increases, right, it leads to damage. Respiratory problem, because lungs are damaged. Arrhythmia, a common thing, because when situations are like that, that SA node, that AV node, right, bichara, as such, they are so delicate, right? But such a small, delicate circuit, they should get at least proper oxygen. Then and then these electronic system, they can work. Oxygen is not they are not getting, so they start working irregularly, and that leads to arrhythmias, right? That leads to arrhythmias. Valve regurgitation, valve failures, cyanosis few days after birth, because again the mixed blood is going as the requirement increases, so it leads to cyanosis. More blood to lungs, less to body, because high to low pressure system, right? The blood goes from high to low pressure. Right ventricle is bichara low pressure, left ventricle is high pressure. So left ventricle does the dadagiri, right? It pushes the blood into pulmonary system. So body is getting relatively less blood. So that leads to finally fluid overload and the heart fails. Again, this thing is associated with 22q11.2 deletion syndrome, the microdeletion of 22q11.2, and treatment is nothing but surgical repair, right? There is no other way out. The fourth thing, hypoplastic left heart syndrome. See, this is like fourth thing, right? Congenital underdevelopment of left heart. Right from the beginning, the side of the heart which has to work more, it is bichara weak right from the beginning. Primary congenital heart defect, right? So reduce flow through left ventricle to left outflow tract, because left ventricle itself is so chota, right? So it affects other heart malformation, definitely. Underdeveloped left ventricle. So if the left ventricle is underdeveloped, ascending aorta has got no class, right? Because ascending aorta will say that when the left ventricle is so weak, so small amount of blood is going, so it will also not develop. Aortic mitral valves affected, narrow or absent, which is called as the atrasia. Because when the ventricle is not developing properly, so then there would be problem in the mitral valve. When the mitral valve is not developing properly, there is the aorta problem in aorta. So then there is problem even in the aortic valve. So they are either narrow or absent, right? So this is the complete left side of the heart. Left side of the heart is now affected, right? If untreated, left-sided heart failure, and which is called as the cardiogenic shock, right? The heart is failing at all to push the blood, death is inevitable, right? ASD or PDA required for postnatal survival. See, interesting thing. Now, instantly, this one sentence would make the complete meaning. Atrial septal defect, right? We draw the heart, right? But this time, we'll draw it the way it is. We'll draw it like this. We'll draw it like this, right? This is the left atrium. This is the left ventricle. This is which are its छोटी सी aorta, right? This is right atrium. This is right ventricle. But now, if there is atrial septal defect, yes, this blood will go, right? And so there is some chance. And patent ductus arteriosus, all-time lifesaver, right? It is this. PDA, patent ductus arteriosus. So via that, the blood is going. So this is for postnatal, means after birth, right? After birth, the survival is because of this. So yes, without my telling, you will say then when we encounter such thing, What should we give to the patient immediately? Patient means, I mean, the baby is born, right? In the treatment, what should be started first? What will you start first? What will you start first? If the moment the baby is born, you will be starting with prostaglandins, right? Prostaglandins. Prostaglandins. Very good. Very good. That's right. Right. So symptoms, respiratory distress, yes, poor feeding, failure to thrive, failure to grow, left-sided heart failure, very, very easily understood, right? Diagnostic imaging, prenatal ultrasound before birth. That's why the high resolution, high res ultrasounds, they are needed very much. Nowadays that it has become a practice, prenatal ultrasound, and in that, if you watch anything else but this, for the CHD, congenital heart disease, and especially for these transposition of great vessels and plus this hypoplasia of left heart, this is to be seen very properly. That's why proper chamber measurement and their volume, everything is measured. Chest x-ray, cardiomegaly, right, that is seen. ECG, you'll see the right ventricular hypertrophy, and now you are the big boss in right ventricular hypertrophy, right? You know that it will lead to right atrial deviation, right axis deviation, and plus you'll see the tall R wave and the deep S wave into V1 and V5, V6 respectively. Surgery, surgical repair, right? There is no other option but to do that. Yes, now we come to this fifth part. This is very, very interesting. This is total anomalous pulmonary venous return, right? Total anomalous pulmonary venous return. TAPVR. Again, all combinations, right? Anomalous connection of pulmonary veins and the heart occurs during first 8 weeks of fetal development. So that means there is some anomalous connection. Anomalous means incorrect connection, something which should not have happened. That happens. Some incorrect connections. Now, in order to understand this, we have to simply draw. We draw and we understand. Two things. In fact, three, right? Supracardiac, cardiac, and the infradiaphragmatic. Let's start with the supracardiac. Supracardiac, something which occurs above the heart, right? Pulmonary vein. Now, for this, let's first draw. Let's first draw that, say, our heart, right? This. Here there is pulmonary trunk, and this one is aorta. And over here, this is superior vena cava, inferior vena cava, and the pulmonary veins, right? Pulmonary veins. This is what is happening, right? This is normal. Supracardiac, pulmonary vein open into brachiocephalic vein, right? Now, this superior vena cava, it is formed by what? Brachiocephalic vein, the combination of brachiocephalic, right brachiocephalic vein and left brachiocephalic vein, correct? They both combine to form the superior vena cava. Now, I'll draw this thing with this. Either the pulmonary veins, they are opening into brachiocephalic, or they are opening into superior vena cava. Getting the idea? Right? This is what is called as the supracardiac variant. Pulmonary vein open into brachiocephalic veins or superior vena cava. Now think of pulmonary vein will do what? Pulmonary veins, they are getting wonderful oxygenated blood that we are pushing into the system which is already deoxygenated. So that oxygenated blood, right, it comes here, right? Once again, from pulmonary trunk, it is going into what? It is going into lungs, right? What body will do, right? Aorta will say, मैं क्या करूं, right? So this is supracardiac variant, right? The second variant is the cardiac variant. We draw it here. We draw it here. Cardiac. In this, what happens is pulmonary veins, they open into coronary sinus or right atrium directly, right? So again, right, this is the SVC, IVC, and this is normal, the pulmonary vein. Now pulmonary vein, instead of opening into superior vena cava or brachiocephalic, directly opens into right atrium, right? So this pulmonary veins, instead of this, they are opening into right atrium. Now this is the worst. Or it will open into that coronary sinus. You remember coronary sinus? Coronary sinus is where all those veins meet, and then that coronary sinus opens into the right atrium, correct? Right? So the way, so that is like coronary sinus, coronary sinus. So all those coronary veins, they meet at coronary sinus, and that coronary sinus, it opens into right atrium. So pulmonary veins either open into coronary sinus or right atrium. Gone, right? Or the third thing. So this is the cardiac variant, right? Pulmonary vein open into coronary sinus or the right atrium. And then comes the third variant. Pulmonary vein, this is the worst. It straight away opens into portal or hepatic veins. Now remember, portal or hepatic veins, right? You remember where exactly they were happening? It was happening. See, that's the liver, right? We have got the hepatic circulation, that is the portal circulation, right? Portal circulation, systemic circulation. In systemic circulation, which goes into the entire body, right? This is when the splenic vein and those mesentery vein, they open, and there is a formation of portal vein, right? Portal vein. It is this portal vein, what it will do, these are the mesenteric, right? Inframesenteric, supramesenteric, and the splenic. So they will carry, see, these mesenteric veins, they will be getting all the nutrition, right? And then it will be going into the liver for processing. In liver, once it is done, then it will be coming out, right? It will be coming out. So here they will be like hepatic veins, right? What hepatic artery will do? Hepatic artery, that will be giving oxygen, right? That will be giving oxygen to liver to function this. While this is a metabolic system, so that's why this is called as the portal circulation, right? Portal circulation. So, right, I think this part is clear, right? So over here, these pulmonary veins, they open here, right? Those pulmonary veins, they are opening into hepatic vein or the portal vein, right? So that is where they open. So this is obviously infradiaphragmatic, right? This is below, right? Yeah, there is no blood in the left side of heart. That's right, right? So over here, and the variation is like that, there would be some veins even open into the left atrium also, right? It's not so that nothing opens. Few veins, they will open on the left atrium, but they will open into the right atrium also, right? Because there are veins are multiple, so not all the veins, they are getting incorrected, right? So again, because if all the veins are over there, so then the baby won't survive, because there is literally, it is empty, right? But it never happens. At least few veins, so they open into left atrium and it keeps on working. But when it is coming to infradiaphragmatic, the most important thing is that there would be hepatomegaly. The liver would be enlarged, hepatomegaly, right? Because hepatomegaly, you are pushing large amount of blood from the pulmonary, and via portal vein it is going into the liver. The liver is bound to enlarge. That is what is called as the hepatomegaly. Now there can be some mixed variants, right? There can be some mixed variants. So oxygenated blood travels through pulmonary vein to right atrium to right vein, right? Right veins. Blood does not leave pulmonary circulation, so that there is no systemic circulation. This is this is incompatible with life unless once again lifesavers have come. Foramen ovale or patent ductus arteriosus present, right? So even if the entire thing has come up on this side, there is not a single vein over here, but it is that patent, that foramen ovale, right? It sends. Got it? It sends. And then it goes into the circulation. Or whatever the blood which has escaped here, over there, right? Over there, this is what? This is pulmonary trunk, right? This one is aorta, this one is aorta, and again another lifesaver comes into picture, and that one is ductus arteriosus. So once again, it survives, right? So as such, not all the veins they open, but sometimes if all the veins are opening, still this foramen ovale and patent ductus arteriosus, they are the survivors, right? So oxygenated and deoxygenated blood mix, yes. Established connection between pulmonary and systemic circulation, yes, as such. Till the fetal life, as such it is happening, right? But anomalous connection often accompanied by pulmonary vein obstruction, pulmonary venous hypertension, and severe cyanosis. This is what is seen after birth, because here there is stenosis, right? Usually this is accompanied by pulmonary stenosis. Till when there is fetal circulation, right? This is not playing any role because as such lungs are not functioning. But now when there is pulmonary stenosis, postnatal, right, post birth, right, it will lead to cyanosis because of this one important association, and it is pulmonary vein obstruction. Right, before birth, right, it was not of much importance, but now, yeah, because they were already there, and in any case during the fetal life we were not interested in sending any blood to the lungs because as such lungs are not functioning. But now when the lungs are functioning, that pulmonary stenosis is leading to cyanosis, right? So symptoms, sorry, severity of symptom, they depend on presence or the degree of obstruction, right? If the stenosis is severe, there would be cyanosis, there would be tachypnea, there would be tachycardia. Heart has to work more, so that whatever the oxygen is there, right, keep circulating. Dyspnea, breathlessness, failure to thrive, because as such less oxygen is available, so tissues won't grow, and recurrent respiratory infection. And yes, this is what we said, right? Liver enlargement, there is hepatomegaly. And this is what is called as the snowman's sign, right? This is snowman's sign, which is classical for total anomalous pulmonary venous return, TAPVR. This is called as the snowman's sign or the figure of 8. Snowman's sign means, right, this is like a big head, and this is like this. So, right, that's the snowman, right? That's the snowman. So over here, you will find that why this thing should really occur, this snowman sign. See, so this was, I'll just remove this, right? So this is like snowman sign, snowman. Dilated superior vena cava here, pulmonary vein, right? Brachiocephalic artery above, right? They actually form the head, right? So divide like this, right? So this one is SVC dilated, right? Then there is pulmonary veins, they will be dilated, so that's why that bulge, and the brachiocephalic artery. So this is the head part of the snowman, right? So that's the head of the snowman. And this lower one, this, right, that entire bulge is because of dilated right atrium, right? Right atrium is dilated, so that's why this forms the body. Right? So this is what is called as the figure of 8, right? So this is figure of 8 sign, or the snowman's sign, right? Or the snowman's sign. So when such double things is seen, it is like a spot diagnosis. That is, we are looking at the TAPVR, total anomalous pulmonary venous return. So over here, right ventricle and pulmonary artery volume loading. So this might show left atrium with no connecting veins. That's what we talked about, and that's what you really asked, right? In left atrium, there are no connecting veins. Can happen, right? Or some veins are there, or otherwise, so they are coming via foramen ovale, right? The blood is coming via foramen ovale. So in ECG, we'll see the right ventricular hypertrophy. And when right ventricular hypertrophy, so this is right axis deviation, and rest you know it very well, right? So these are the 5 major things which you see in the right to left shunt. Regarding these vascular malformation, 3 types. One, what is called as the Kaposi's sarcoma. This is a sarcoma, right? So this is a malignant tumor of endothelial cells. So seen in patient with suppressed immune systems and skin lesions. Right. The second is this hemangioma. Hemangioma, this is benign, right? Sarcoma is malignant, right? Remember that. So hemangioma is benign tumor of endothelial cells. And then comes the angiosarcoma. Sarcoma, once again, the malignant cells, the liver blood vessels. So this is like an occupational hazard. So vinyl chloride, arsenic poisoning, they lead to this angiosarcoma, right? Malignant cells. Finally, this is arteriovenous malformation. In arteriovenous malformation, so this is the artery, divides, right? There are capillaries, and then they combine together to form veins, and finally the veins. So there is a single connection between arteries and vein, and that is what is called as the arteriovenous fistula. So this is capillary bed, right? This one is called as the capillary bed. That is called as the capillary bed, and via this capillary bed, the tissues, they are getting all those the nutritions and the oxygen and carbon dioxide exchange. What if this is a bypass, right? There is a single connection between this artery and vein. That is what happens over here, right? So this is what is called as the AV fistula. AV fistula, or the arteriovenous fistula. So most often it forms in brain, spinal cord, and lungs. So when it happens in brain, so if they rupture, they lead to neurological symptoms, right? And later it leads to heart failure, right? Because it is leading to the volume overload. So that's it for today. So this was the complete journey of congenital heart disease, right? We talked about acyanotic and cyanotic, right? So thank you so much, right? And we meet next time. Thank you and bye-bye. I'm putting this file into our folder, right? Just within a few minutes. There are few CHDs, but they are extremely rare. For say MBBS level, so this much is more than enough. More than enough. No one will ask you in this much detail, but once you have known this is more than enough. Oh yes, happy Republic Day to you too. Thank you.